So just to welcome everyone, thank you for joining today's Homeless Health Community of Practice, where we will be talking about supporting inclusion health groups with GP registrations and access. This event has been convened by the Healthy London Partnership Homeless Health Programme. We have a series of speakers joining us today. Further ado, I will hand over to our first speaker, Dr. Jasmine Malik, who will run through today's session.
Hi, hello, and thanks for that, Alicia. Welcome to everybody. It's great to see you here. I will just pull up the presentation as we're starting. So I'm Dr. Jasmine Malik. I'm a GP with an interest in inclusion and homeless health. I'm a clinical lead for apologies there, that's gone on to the first slide. I'm clinical lead for homeless health and mental health for North Central London, and I'm also co-clinical lead for Healthy London Partnership. So yeah, as Alicia was mentioning, we've got quite a packed agenda today, and I'll kick us off and start us with going through the GP registration standard operating principles for primary care. And that will be followed on by Dr. Armina Verity from North Lewisham PCN, who will outline findings from a GP mystery shopper project that she undertook. We'll then hear from Henry Sinclair Miller from Islington Council, who will outline considerations for those with no recourse to public funds. And then from John Driscoll, who is a care navigator from Groundswell, the Homeless Health Peer Advocacy Service, who will outline the challenges faced during registration from a lived experience perspective. Then we'll hear from Doctors of the World, Emmanuel Serrano, who will be talking about the Safe Surgeries Initiative, and from Dr. Elaine Moorsman, who is a GP SC2 at the Corner Surgery. She will take us through and talk to us about an experience from a London GP practice becoming a safe surgery. As the schedule's quite tight, what we'll do is we'll have a couple of minutes of questions after each of the speakers. And if you don't mind, like Alicia was saying, to place the name of who the question is addressed to in the chat, and we can then discuss and go through them in that 2 minutes. If we don't have time at that point, we can try and pick up the remainder of the questions at the end of the webinar. If again there's not sufficient time in that respect, then we can collate the specific questions and provide written answers which we can circulate following. Okay, so let me just make sure I can get onto the next page. Okay, so for some reason, I'm having some problems getting to the next page, Alicia. Oh, let me see if I can do it this way. Yep, here we go. Ah, lovely. All right then. So yeah, so these are a couple of headlines that I've kind of come across in the past year or so, and it's kind of despite a significant amount of effort that's been put in from numerous organisations and people over the past decade, really to sort of outline the issues in regards to trying to ensure access to general practice and primary care services, we're still seeing that there are issues in regards to this process and challenges for those who are either homeless or from other inclusion health groups. So I'll be laying out the legal situation, which most of you will already be aware of. But just in case there's any ambiguity, there's a lot of links that I'll be sharing in today's discussion, and the other speakers on the call will go into a bit of a deeper dive in terms of the aspects of the policies and things. So the Primary Medical Care Policy and Guidance Manual contains the GP patient registration standard operating principles for primary medical care. It was updated earlier this year in February, and there was no changes to the national policy in respect of patient registration. However, this guidance really sort of clarifies that the rights of patients and the responsibilities of providers in registration with a GP practice, and with particular relation to those who do not have ID or the necessary documentation. The overall aims, really, in terms of sort of this management is this policy is to reduce the risk of worsening health inequalities for the vulnerable populations, such as those who are asylum seekers or homeless, and to really promote equality, human rights, and public health. Highlighted here in green, this area which could potentially lead to confusion when you're going through the 400-page documentation. Now, I've highlighted it purely because if you take this text in silo, in absolute isolation from the other paragraphs in the policy, you'll kind of sort of have the context of it sort of taken out of context. So what, in terms of what was fed to me earlier this year, was a section through which people in practices were referring to and outlining to me the content of this particular paragraph and how they sort of base their practice policy. It's sort of having a strict policy in place requiring documentation for registration. And as such, based on this, there was refusal and delayed registration as a consequence. So as I said, if you take it in silo and don't look at the sort of rest of the context, then, you know, sort of, you know, it is easy to confuse what is being written and said. And it's quite clear as the policy kind of goes on, and I've underlined and sort of highlighted this particular aspect in red, just really sort of that it's, you know, shows that there's a clear statement that there is no requirement under the regulations to produce identity or residence information, and that patients must be registered on application unless there's reasonable grounds to decline. Now, lack of documentation is not considered to be reasonable grounds for refusal. I've sort of included this aspect here as well because it's really important, because if the administrative team find that they suspect possibly that there's patient fraud, it's still the duty to register the patient and to—
We've done this already.
And for the
yeah, I've done that already. Yeah, I don't know why I'm on that.
Sorry, just to if you're not speaking, do you mind just popping your microphone on mute? Thanks. So yeah, so in terms of if there is suspicion of any particular patient fraud, then in terms of yeah, as I said, registering the patient, treating the patient accordingly, and referring up to the services, sort of NHS counter fraud authorities. The links are here. So, I mean, then in terms of sort of additional information that sort of I thought was useful to kind of to highlight was the CQC sort of website has a website details on myth busting, and they've looked as one of these myth busting pages is looking after homeless people within general practice. And again, they've outlined what the sort of expected standards of care should be and examples of good practice as well. The links are also here attached there. And then in terms of the British Medical Association, they also outlined the guidance on registering patients without proof of identity or address, and highlight that both the BMA and NHS England are committed to ensuring that homeless patients receive the same level of care as those with permanent addresses. This next link is a link which will take you to the Pathways website, which has given a more in-depth outline of standards for homeless and inclusion health groups contained within this document, and it's been endorsed by a substantial number of organisations, as you can see here. I've also included a link here in terms of Primary Care Support England, and obviously, as you can see on this page here, they also indicate reasons and how to do I register with for homeless patients. From conversations that I'm having with practices at present and sort of trying to sort of discuss sort of the barriers which are in place, there are issues.
Oh, Jasmine, you've just muted your line.
Thank you. When did I mute?
Just the last few words. So primary, just the Primary Care Support England page, and then we lost you for a few seconds.
Thank you so much, Alicia. Apologies. Okay. Yeah, no, I was just saying that so on the website that they do provide sort of information in regards to how to register homeless patients. And I have been discussing with practices and sort of understanding that there are continued challenges in relation to this process with regards to PCSC, and that delays can go on for up to 6 months, which is obviously extremely challenging. I won't go on to that too much further because I'll be handing over to Dr. Armina Varity, and she'll be able to go into that in her discussion a little bit further. So I'll stop sharing now and just open up to see if there's any particular questions that anybody's wanting to be raised. So I can see quite a few in the chat there. Alicia, have you been able to?
Yeah, no, we've just had one question just asking about the slides, which will be made available after the session, including the links which Jasmine has just been talking us through. Please do submit any other questions you have as we go. Seeing one which has just come in, Jasmine, can those experiencing homelessness report a surgery for refusing to register them?
So from my understanding, if you are refusing to register a patient as a practice, you should be making documentation and sort of an outline of an explanation of why you're refusing the process in the first place. And that should be available for commissioners to see if they were to ask and sort of delve into it further. So in that terms, they can, as I said, it's their right to be able to access healthcare. So certainly there's a couple of, as I said, in terms of those headlines that I've outlined there has been looking into that and the patient experience as well. So certainly, yeah.
Great, thank you. That's the only question we have at the moment, so we might take us on to our next speaker.
Great, thank you. Armina, do you want to take it?
And again, everyone, please do continue submitting questions as we go. Questions, links to resources, case studies, all very welcome to be shared in the chat.
So thanks very much, Jasmine, for that really clear overview. So my name's Armina Verity. I'm a GP working in North Lewisham in South London, and I'm also the GP Fellow for Health Inequalities for my primary care network. And what I'm going to talk to you about is how the move with COVID and moving to kind of more remote access and total triage had an impact on health inequalities. And the focus of my work was looking a bit more broadly than general health inequalities, as well as including obviously those experiencing homelessness. So these slides will be shared, and there's a link on the next slide with the full study write-up, which you can get a full list of exactly what we did and the results in lots of detail. So I'm just going to take you through a whistle-stop tour. But we did interviews with key stakeholders who provide support services to vulnerable patients, and we got some feedback for some Black and ethnic minority patient forums that Healthwatch were running. We did a survey to GP practices in Lewisham, and we did a mystery shopper exercise of the 10 practices that comprised of our primary care network to see what access was like following the move to total triage. And this project was done in May 2020, so right kind of just after the first wave of COVID. And the reason we did this was that anecdotally we saw that there was a significant decline in our complex and vulnerable patients presenting. So I think you know, anecdotally, many people who work in primary care have seen this, that total triage and remote consulting has worsened existing barriers. So a lot of our patients in inclusion health groups, they have chaotic lifestyles, they struggle with poverty, language barriers, a difficulty prioritising health needs and a mistrust of the system. And total triage and remote consulting made all of these more challenging. However, there were some new barriers to access that hadn't existed before. One of the main things was around messaging. So at the time, there was really poor communication from general practice to the population about how to access GPs and what the new situation was, which was, of course, was understandable given the pressures we were under with managing the pandemic. But in July, when the Health Watch did their survey in Lewisham, 20% of their 1,300 respondents still thought that GP practices were closed, despite the fact that we never actually closed. There's difficulties with kind of sharing information through triage when you haven't built up trust and rapport, removing the ability to walk in. So lots of our patients who are vulnerable and maybe struggle with prioritizing their health needs need that walk-in route, and that was something that we saw has struggled. And I think, you know, these are signs, pictures of the practices in our local area that they had put on their front door. And so you wouldn't be wrong in assuming, you can see how that miscommunication had happened when these were in place. And actually several of the surgeries, so 4 of the surgeries had closed their doors, and 3 of them you had to ring an intercom to get into the practice, and 1 of them you had to call a number. So if you're someone who doesn't speak English, or looking at those posters, you can understand there's a perception that actually my GP surgery isn't open anymore. And then I think digital exclusion, most people here will be aware that you know, a lot of practices moved to digital first triage as recommended by NHS England, and that there are many people who can't ever get online for a number of reasons, and there's probably the people with the highest health burden. Several of the practices were offering online only registration and online only first triage appointment requests. So if you can't get online, then you can no longer consult in those practices. And out of the 10 practices, 4 out of 10 of the practices refused to register a patient who didn't have proof of ID, address, or internet access. So what did we do about it? We came up with some recommendations, which I think are very similar to the ones that Jasmine has highlighted, you know, in the CQC, and many other places have made similar recommendations. But I think the key thing that we found from this quality improvement project was that there will always be patients who cannot access remotely or digitally, and these are the patients with the biggest healthcare needs. So there's a need to have an inclusive triage system, and including a direct face-to-face option, clear and consistent messaging about how to access GP. NHS England has helped with that with some centralised communication strategies, which came out later in the year around September time. And then those kind of obvious things around continuity, face-to-face care when appropriate, having flexible appointment lengths to allow for multiple issues to be dealt with. If you have a read of the study, there's, you know, we've gone into a lot more detail. So following on from this, my primary care network employed me as a GP fellow for health inequalities. And they, so we have been doing lots of pieces of work, but one of them is around improving GP access. So one of the first things we did was an admin focus group. So we got together all of our administrators in our PCN, not all, a representative from every administrator, and asked them why did they persistently refuse to register patients who had lack of ID, lack of proof of address, as demonstrated by the mystery shopper. And this issue that Jasmine said before about PCSE putting up blocks around registration was part of the problem. So essentially, if it's not a simple, straightforward registration, PCSE tends to query or reject registrations, and it can take upwards of 3 to 6 months, we were hearing from our administrators, to actually register these patients. So actually, you're massively disincentivizing your reception staff to do that work if they can either say no and not have to deal with 3 to 6 months of back and forth with PCSE, or they can get them in. There was also a lot of anxiety around what to do with these, with like if they were registering the wrong patient, or the potential for fraud was a really big anxiety that administrators had, and it seemed to overrule the anxiety around turning someone away who might need medical care. So fraudulently registering registering a fraudulent patient was seen to be more serious than not registering someone who needed medical care. The other thing we're doing is looking at an audit of every practice's appointment booking and triage system, testing it with the community and GPs to see what's working and what isn't, and then providing some clear and consistent PCN-wide messaging and guidelines to do an inclusive and equitable triage and booking system. And then we've worked with Doctors of the World to do some adapted safe surgery training for all of our practices once we have some more information around that. Just briefly as well, the kind of other work that we're doing. So we've contacted 150 community organisations and 32 of them fed into a stakeholder mapping looking at the causes of health inequalities. And at the time we were looking at poor vaccine uptake. We've got a community link worker who's someone who has done 25 years of community development work in North Lewisham. And she's now employed by the PCN under the R's role to act as a bridge between the community and practices. And we're also setting up this North Lewisham Community Forum, which is running our first event in October to try and just create more of a dialogue between the community and build back some of that trust that we've lost from our patients who experience health inequalities. So recommendations, kind of broad brush from what we did. So if you're an administrator, I would say the main concern should be not to send someone away who cannot access healthcare, rather than worrying about fraudulent registrations. Let your GPs and practice managers worry about that. And we're hopefully going to be working with Healthy London Partnership to escalate this PCSE problem on a national level to see if we can talk to NHS England and PCSE about what's happening. Clinicians and practice managers, think about your triage and appointment booking system. Is it inclusive? Is it flexible? Do patients understand how to make appointments? And do you need to do more work at getting some patient-facing messaging out there? And if you're a commissioner, can you think about health inequalities differently? So there's the SPIN fellowships, which are HE funded for first 5 GPs. You could get a GP fellow funded on that. It wouldn't cost your PCN any money to get them to start thinking about a programme of work around health inequalities. And I think the PCN level is a really good level to look at this. And then think, interestingly, about your R's roles and how you could use them in your PCN. So I'd like to thank all the people you can see listed on this slide who've helped with the study and the work that's ongoing. My email address is there. I'm very happy to be contacted, and I'm happy to take if we've got time. I know I'll probably overrun a couple of minutes of questions.
That's great. Thank you, Amina. Really interesting findings from the exercise. So we've had a couple of questions in. One of them, the other panel members are welcome to join in as well, but the question was that some surgeries have been known to refuse homeless patients by saying that they are at capacity, and do we think this can be challenged?
I can say a few words. Yeah, do you want me to? Yeah, so I mean, in terms of capacity and the list being closed, that is with an agreement with commissioners again as well. So list closure will be with that agreement in place. So if it is being challenged, then certainly avenues up to the commissioners to just inquire if list closure is the actual issue and problem there.
Thank you. And another question which was submitted ahead of today's event, you mentioned registrations, Amina, and someone asked how to confirm that a patient is who they say they are without ID. They're known to be homeless, but they haven't got an ID. Are there any kind of steps or solutions you might have to help answer that one?
So I think what we were talking about is that the primary focus should be that they're not blocked from medical care whilst you work that out, and that you have sensible policies in place in your practice to make sure that you're not thinking about doing things. So the most common reason for like a fraudulent patient registration would be drug seeking behaviour. And so the way that you can do that is making sure you've got a clear practice policy in place that you don't give out, controlled drugs until you've either got a previous medical record, or if you're doing it, you're doing very, very short courses, limited and incredibly, monitored by a GP. So I think in terms of, and then as Jasmine highlighted, referring to the NHS fraud unit so they can investigate, and just taking the pressure off practice staff to feel like it's their responsibility to do this. And I think that's one of the things that we identified from the focus group, that actually for some reason administrators in the NHS are feeling like that's that's a priority for them. Whereas I think we need to change the focus and say that actually there's a significant number of people that are being refused medical care regularly, which is leading to significant morbidity and mortality. And let's focus more on providing them with care and let the commissioners and the fraud department worry about that. I don't know if you want to add anything, Jasmine, or anyone else.
No, you've absolutely covered it there. And, on the previous slide that I showed, there's the contact details that people can flag it up to. But the main key really is ensuring that they're registered. That's the duty of the practice, to register them, and that they have the access to healthcare and treatment.
That's great.
On that point as well, you've got the fact that some of the surgeries actually take the key work, like the support workers and that can actually sign to say that we've known the client for 6 months, and then we can actually, they will use that as the client's reference to say that is the client and that is the person that we are dealing with. So I've had that where I've had to sign consent just to say that I've worked with the client for 6 months and I know who the client is, and that works as well.
That's great. Thanks for that, John.
Thank you. And I think we will now move on to our next speaker. So I'd like to introduce Henry St. Clair Miller, who will be giving us an overview on no recourse to public funds. Over to you, Henry.
That's brilliant. Thank you, Alicia. Let me just start by sharing the screen. That's the first challenge. With any luck, that is showing. Is it, Alicia,
Yep.
okay?
Yep, that's all good.
All right, thank you. Well, thank you, Jasmine and Amina. It's been really interesting to hear the presentations so far, and from a local authority perspective, we certainly have had people who have struggled to register with GPs. So the information you've given is really helpful to our practice. I will just say a little bit about no recourse to public funds and what this means. So public funds are benefits and any support you're going to get from your housing department, such as homelessness assistance. And it applies to people who are subject to immigration control. If you want to have the full list of public funds, you can refer to the NRPF network website for more information. And something that I always say when I'm talking about no recourse to public funds is that there are plenty of other taxpayer funded services which are not public funds for the purpose of the NRPF conditions. So the two obvious ones being NHS support is not a public fund. Any support provided by social services is not a public fund. But I have to put in a strap line that says, well, for some of these services, there might be limitations as a result of people's nationality or immigration status. Fine. But as practitioners, we need to be clear about what those limitations are in order not to discriminate. And we should know what those restrictions are specifically and not jump to any conclusions. And I think that's a message that has been coming out of the presentations so far. Now, because of the NRPF condition, you encounter a range of people who struggle to access benefits and housing. Again, these slides will be sent to you, but it's just an example. We have people who are here with a form of leave, but with the NRPF condition imposed. We also have people who do not have any immigration permission at all and are subject to immigration control and will not be able to get benefits and housing. We have also seen a number of changes for European Economic Area nationals following the end of free movement rights, and we now would encounter European Economic Area nationals with different types of status depending on where they are in all of this. People who have already applied under the EU settlement scheme and have status, or there might be people we encounter who haven't applied but should apply and might be able to make a late application. And then from the 1st of January 2021, we are going to have European Economic Area nationals entering on the new immigration system. And for each of these groups, there may be challenges accessing benefits and housing, which contributes to challenges we face when tackling homelessness in our communities. So I'm going to look a little bit about what some of the support options are for people who are at risk of homelessness. We have a situation that no recourse to public funds means people can't get benefit and housing, but social services support is not a public fund. And what this means in practice is that social services may provide support to prevent vulnerable people and children from being destitute and homeless. Social services perform the role of a safety net, and this safety net is available to adults who have care and support needs under the Care Act. It is available to families with children under the age of 18, and it is also used to support former relevant children who at the age of 18 do not yet have immigration status that permits recourse to public funds. Whereas for children in families, the question is whether the child is destitute. That is the only consideration when we're looking at the child in need assessment. If the child is destitute, the whole family can be provided with support under Section 17 of the Children Act. It is not so open, this safety net, to adults because they must have assessed care and support needs. It is not just about destitution when it comes to social services support for adults. If you are making referrals to social services, you will need to make sure that you know which social services is responsible, which is about ordinary residence and physical presence in that local authority area. Anything you can do to help ascertain immigration status is useful. Immigration status is useful in terms of signposting. It's useful in terms of knowing when we need to refer people to get immigration advice. Might help you determine whether or not someone has recourse to public funds or not. But of course, none of that gets in the way of meeting urgent need. If there is an appearance of need, we've got to step in, we've got to provide support. If you do make a referral for a vulnerable adult or for a family, then you are going to be expecting that social services complete their statutory assessment, which for adults would be the Care Act, and indeed for families, the child in need assessment to see whether the safety net applies. It can take time to complete an assessment, so the local authority is empowered to provide emergency support pending the completion of assessments as required, if required, and the outcome of any of these assessments should be provided to the person with a written explanation of what next in their case, whether that is someone who's going to be eligible for ongoing support or not. These are the gaps, so I'm going to move on now to other support outside of that social services safety net. We saw during the pandemic that if there is a public health emergency, there are wider powers under the Local Government Act and the National Health Services Act that can be relied upon to accommodate people who are at extreme risk. And that is the backbone of what has been called the Everyone In response, which was generally led by housing departments to get people off the streets to prevent transmission of the pandemic, of the virus. Now, where we're looking at other supports, then we are often having to engage with VCS organisations. So, for example, we have seen Southall Black Sisters stepping in for victims of domestic abuse where there is no support available. We also will remind people that there are other VCS organisations like the No Accommodation Network that will have information relating to projects providing non-statutory accommodation, which may be of use to you when you're trying to avoid people being destitute. We also have the asylum system. So if people are asylum seekers or failed asylum seekers, you may make referrals via migrant help to access asylum support from the Home Office as an alternative to being street homeless and destitute. And we've also seen a number of trafficked and modern slavery cases, and just making people aware that local authorities have a duty to notify the national referral mechanism as a first responder where people are seen to be potential victims of trafficking. And indeed, that can also open up a support route through the Salvation Army. More information can be found on those different support networks through these links. And in some cases where nothing works out for the person, perhaps there's no application to make to the Home Office, then even if return to country of origin is not what people normally wish to do, people should be aware of the voluntary return service operated by the Home Office, as this is open to people who decide to return to their country of origin voluntarily, and may also include reintegration support, financial support to assist with that return. We do say, though, from an NRPF network position, people really should seek legal advice before making contact with the Voluntary Return Service. And finally, these are some of the next steps that you can think about in your practice. So identify patients who have no recourse to public funds, be proactive in doing that, understand what those immigration issues are, and help make referrals to immigration advisors who might be able to recommend what they can do about the fact they have no recourse to public funds and potentially no immigration status. Often this matter is resolved by an application to the Home Office, which, if successful, allows recourse to public funds. And our data shows that for people who are supported by social services, about 77% of the people supported do go on to leave support because they've been granted leave to remain or another form of status permitting recourse. So that's a good thing we can do. If you do identify somebody, and I saw someone in the chat talking about hospital discharge, it was Matthew Skinner. Well, we need to make sure that we are referring to adult social care if there's a concern about hospital discharge or other vulnerabilities relating to the person, because they have a statutory duty to do a Care Act assessment. If you're making a referral to social services, please provide supporting information and evidence to help with that. And as people are already doing, as we hear on this call, making those links between different social care teams with local authority staff, with housing departments, with the outreach teams. This is an excellent model, and we've been putting that into use with partnerships between local authority and NHS staff and primary care staff. We've been doing that in relation to some of the recent challenges of asylum hotels, and more recently the Afghan bridging hotels for refugees and evacuees. So this is a really good way of working together around specific issues, with homelessness, of course, being one of those more permanent issues that we are trying to end. And also think about our signposting locally. Who are the lead organisations that can help in your local area to assist people if they need additional support around their welfare, around their housing, around their well-being or immigration matters. And indeed, as a local authority, if I just put my Islington hat on, I'm also having to think about what referrals I can make to NHS and primary care staff to support the people that I am assisting under the Care Act and the Children Act. So in a sort of whirlwind, that's everything. And I will just say that if you need further information, we've got information on our website relating to this for you.
That's great. Thank you, Henry, for a really comprehensive overview. You did kind of address one of the questions which had come in, which was about how surgeries can keep track of patients discharged back into homelessness, those who are elderly, serious illnesses, comorbidity. Just if you have anything else to add to that, or if any of the other panelists would like to add their own thoughts on that question.
Yeah, so in terms of the discharge teams who should be working to sort of ensure there's a safe discharge. Obviously, people who are discharged back to the streets is something that we're trying to end across London and hopefully on a national perspective as well. And in terms of that liaison, sort of that work, you should be expecting sort of information coming through from a discharge team to inform you that somebody is being discharged and serve sort of if there's any additional work that's required or sort of continuation. In some circumstances, you can sort of hopefully get a phone call through, so that highlighting and flagging the need and sort of particular around any medication that needs to be continued and sort of managed in terms of prescriptions within the community. But yeah, there's quite a lot of work going on in terms of working around sort of the discharge teams and sort of assisting that safer discharge pathway.
Yeah.
Thank you. I see we have a hand up. So Prince, it'd be okay if you'd like to jump in, please do.
Yes, if I may. Just in terms of the discharge, we have a wonderful model, which I think is something that I would like to recommend, and that is we should really have a system where any time someone who is someone who's homeless or someone who might be at risk of homelessness hits the door for any of our hospital, regardless of where they are presenting to the hospital team, we should really have someone who is, call them a homeless coordinator, a homeless discharge coordinator, or something of that nature, and they should be immediately informed. In fact, there should be nobody who is homeless or at risk of homelessness who comes into the corridors of any of the services in the hospital who should not be known to a person who is responsible for making sure that that person who is homeless or at risk of homelessness is immediately made contact with, and the process for them being discharged, because we like to think that everybody that comes into our hospital will eventually be discharged, the process begin immediately. Okay, and we have a model that actually ensures that, working with our third-party voluntary sector organization. So we have someone who's employed full-time, who's now we haven't got it perfect because not every team in the hospital is letting them know whenever a homeless person comes into contact with any of the hospital services. But however, that's just an issue of education and training, which we're rolling out. And obviously it's continuous because staff turnover and things like that. So, but however, we are getting there, and a lot of the homeless people are known to them, and they can immediately begin to put in place the things that will ensure that no homeless person is discharged or people at risk of homelessness are discharged onto the street. And it's a model which I think really should exist in every hospital where we have an adequate number of homeless people that may well be accessing our services.
Yeah, I mean, just to reflect on that, I agree. And I think Prince's point here is one that we support, is around that need for specialism. It's quite a complicated area, and I think having some specialism to help navigate these cases really helps. And it's something that we recommend, and that sounds like you have that. And I think it's about also looking at cases to work out whether or not statutory responsibilities apply, because if they do apply, then we should use those statutory powers and duties as is intended. But equally, we're going to have to be aware that there are gaps in statutory support, and that's where we're working with VCS partners or trying to attract funding or new ways of working to try and open up provision to avoid people being street homeless. It always just gets more difficult if they have no recourse to public funds, because of course they're not going to be able to get benefits and housing, which is meaning that we're having to come up with innovative alternatives to try and deal with the fallout of that.
I mean, obviously the important thing here is, yeah, I recognize that is making sure that the scope of the duties of the homeless discharge coordinator is absolutely clear. Because one of the things they do is that they are in touch with everybody, including the local authority housing, the social work team. They're in touch with all the VCSE organization, the homeless charities, etc. So they are kind of the central focus point for the homeless person who comes into the hospital and who is eventually discharged. And so they put in place whatever package of support, obviously working with a homeless person, that will be required for when they are discharged. And I think it's pivotal that role, I think that role is a best practice that should really be, I don't know how we do it, but in a national way, we need to encourage that sort of system, and almost like as a model of good practice that people should really look to emulate, and the CCGs should look to commission along with their local authority, because don't forget, such a role is pivotal for local authority and health. So it really should be a joint role, and they both should be looking to appoint such a role.
Thank you, Prince. That's great. Thank you. And I think we've got one other question from Sarah.
Oh, hi. No, that's really great to hear, Prince, as well. I'm not sure which hospital you're from, so it would be helpful if we could know where you're talking about that services. I'm a GP in Islington, but I'm also the medical director of integrated care at Whittington, and we've been doing a lot of work. You're absolutely right. As soon as the patient comes in from a hospital perspective, we need to know, are they homeless? The other thing that we've discovered over the last few years, particularly, is people becoming homeless whilst in hospital. So some of our patients that end up staying quite a long time with, you know, as we know, a lot of these patients have chronic diseases, you know, several chronic diseases. And so it's really important education of staff and to know what to do, their duty to refer, but also coding so that we know and we can plan ahead, and also linking in with surgeries and finding out from the clients, the patient, what borough that they associate with, because often some patients will be in various boroughs, so that, but there may be one borough they particularly identify with, and that helps. I've found in the past, if we've got a link with social services. And also just to mention Groundswell, I know they're going to be talking later on. They've been amazing at supporting us at the Whittington to help with homelessness. So I just want to say a big thank you to that. And finally, we in our integrated care meetings as well, we're starting to talk more about what support we can get in for homeless patients and patients that are, you know, frequent attenders to hospital. And my surgery's become a safe surgery, and I'm really proud to say 8 practices in Islington are now safe surgeries. So the aim obviously is to get to 100%. But I think it was a lovely quote when someone mentions, I can't remember up on the list here, about basically our doors are open to everyone. And I think that's the thing. The key thing is that we must remember that and don't turn anyone away.
That's great. Thank you, Sarah. And just conscious of time, I think you mentioned Groundswell, which leads us nicely into our next presentation, which is, oh, and thank you, Henry, for joining
sorry,
us.
I have to leave. Yep, so I've got a diary clash. So, yeah, okay. Thank you.
Thanks,
Bye.
Henry. And I'm just going to pull up my slides now, and I will then hand over to John Driscoll at Groundswell.
Good afternoon, people. So I'm going to talk about Groundswell and the way we do registrations and stuff like that, and how we work. So as Prince was saying earlier on about the specialist, the services in the hospitals, I work alongside one in one of the hospitals in London, and we deal with the guys from there. So we work alongside the Pathway Homeless team, and we will be getting registrations and stuff like that. So we will go and actually register the clients. Can I move the screen on, please? So we use these cards, we give them out to clients in day centres and stuff like that. So we'll give these cards to clients, we give them to the staff in the day centres. They can then give them to the clients and actually help the clients to register with GPs. So the clients will go to a GP and state with these cards that they don't, like, I have a right to register and receive treatment from a GP practice. We basically say that you don't need a fixed address, no identification, no immigration status matters. So it's all there, and they will use these. If they get refused, we will then go in and actually find out why they've been refused. So I've been into practices and actually spoke to reception practice managers and asked them to explain why the client's been refused or why they're not prepared to do it. And it's sometimes down to, and I don't mean it wrong, it's down to the receptionist showing a book, like guidelines, and say this is how that clients register. So they don't actually understand it. And then when you get a practice manager out and they come out and they will actually talk to you and find out what's going on with the client and find out that the client is homeless and where they are, what day centres they're using, those sort of things come into place. And then they will register the client. So we've had quite a few times where you walk in and they say, no, they're not allowed to register. Okay, fine. We'll walk in behind them and actually find out why that is. So we use these and we've done it. I've just had a registration recently where it's taken like 3 weeks to get every client registered, and that was on an online registration. So I went into the practice last week and found out why it was taking so long, and it was just told that this is how long it takes. So I was like, okay, fine. So I said, can I do if it's going to take longer than this, is the client registered? No, the client needs medication. Well, they're going to have to wait until they can get registered. So I said, okay, can I do a normal registration? Done that in the practice, and within 10 minutes, he's been registered by the practice manager coming out and actually talking to us and finding out what happened. So they've looked into the system, and it was just the fact that it was an NFA, no fixed address. And because he had no fixed address, the system didn't understand that, and then it wouldn't actually take the registration. So it's something so simple, but it's something that confuses the situation. So it's those sort of things that we're seeing. Can I move the slide on again? So then we've done like action updates as well for the clients, so we can show the clients like where we take we've sent these out to GPs, we sent the cards out to the GPs, and we've done the action updates as well about registration, so the clients have seen these and actually working alongside them. And that's where we do that with the research and the resources. That's that one. So this is the organisation Groundswell, as I've said. We have got the NHS cards if people want them for practices, or like if they need them for places, we can actually get NHS cards sent out to you guys, and actually so you guys can be giving them to clients and that, and actually helping the clients to get registered if that's something people are interested in. I don't know if there's any sort of questions or anything that people want to ask.
Thanks so much, John. I just wanted to sort of pull up there, you were mentioning about the sort of registration with the temporary address, and I think there's something in the chat earlier on in relation to potentially people who are in hotels at the moment and registering them or not registering them. And as we've kind of alluded to previously, the primary care support England sort of, should we say, the process of the registration once the application has been sort of requested can unfortunately take quite a lot of time. But the issue is that we need to make sure that the registration process is started, so it's generated. And knowing that it is going a lot of back and forth and to and fro, what you said HLP and colleagues across London are trying to look at with PCSE is to see if we can ease that sort of situation in terms of the registration process and sort of enabling things to happen more swiftly. So yeah, absolutely. I think those cards are absolutely vital and really, really great to have the resource and the link in the chat there.
And I see we have a hand up from Rachel Brennan, if you'd like to come in.
Hi, yeah, thank you. I'm a colleague of John's actually, and I think, you know, that's a really powerful example. So I have a background in primary care as well. So I guess sometimes I feel like there's a bit of the bridge missing. And it seems like from what you were saying about like some of the concerns about reception staff and doing the wrong thing, that it's brilliant that we've got the healthcare cards now and that we're able to give those out to people so they understand their rights. But it feels like we're missing a bit of guidance for primary care staff and actually how do you do that? So there's been a really good, you know, point in the chat about we use our practice address. It's great if you know that, and a lot of practices do know that, but you know, how can we get this kind of good practice out there to support other practices who might not know that and address some of those kind of anxieties as well? So just, you know, not really a question, but maybe something to think about going forward.
And actually another question which we received ahead of today was just for, I think, John, really, if you could start us off, what works when initiating contact with clients who are currently homeless? Are there, from your work, do you have any suggestions on how to, in terms of communication or what to do?
I think it's the approach you take, because it's for us and the way we work is like, for me, my colleague, yeah, we're in Lambeth, so we're doing a project over in Lambeth at the minute, and the project we're working on is we are the first contact with the clients, and it's actually us going in, actually building the trust with that client, taking them out, having a cup of coffee, doing something different. And the clients actually realise, because of that fact that we've got lived experience, and it's the biggest thing that comes into it now. The lived experience. Once you bring in that lived experience and the clients know that we've been there and they've seen that we've got the same, we understand what they're going through and like the issues they have with GPs, whatever it may be, hospital, wherever it is they're concerned about going to, we can actually go in and talk to them and actually reassure them, just make them feel more comfortable. It's actually taking their pressure off them and actually showing them, like, sometimes, okay, let's go register you with this practice. Let's see what happens. Yeah, because sometimes the clients have not been near a GP for sometimes 10, 15 years, some of the clients that we're working with. And in that 15 years, they have never seen a GP. They don't understand the process. They won't understand how to fill in a form. And it's just us going in, doing that form, sitting down with them, actually taking that time and actually building the trust with us and then the practice. So then they can then go in and work with the people, but we will still carry on working with them even after the registration. It might be 4 or 5 appointments that we can actually take them on and actually go to the appointment with them, actually build up that trust with the GP, build up that trust with the hospital, whoever they're working with. We will go alongside and build that up and actually do the report. So like the nurses we work alongside, drug and alcohol workers I work alongside, we're building up all this trust, and then from that they will then go on and engage and do the services that they need to.
Can I just add something to that, John? I think it's an amazing service you guys offer, but I think one of the things that practices need to think about is, do they have the inbuilt capacity to be able, in mainstream practices, to have a half-an-hour appointment, to have that appointment with you as an advocate? And I think if your system is closed, that you're only doing 10-minute appointments and they're only on the telephone, then you're going to struggle to ever build that relationship. So I think that's something we just need to bear in mind when we design our appointment books as well.
We've stepped in that sense as well, because we do a lot of the welfare calls now because of the COVID. We've stepped into that side of things over these during the lockdown. So we were actually doing the calls with the clients plus the GP. So we were doing a three-way call and actually just getting that main thing out. So if it was a 10-minute appointment and the client was saying, "Oh, my main thing is I've got a busted toe." Well, okay, we'll talk to the GP about that and then we'll work through the other things. And sometimes it was actually booking, sometimes actually saying, "Okay, I need a 20-minute appointment." And just explaining to the GP what it was for, or the receptionist in the practice, and then working it with them.
That's great, thank you both, really good. I've also linked to the Groundswell peer advocacy service in the chat, so please do go and have a look. I think we'll move on now to our next presentation, which brings in our colleagues from Doctors of the World, who'll be talking about the safe surgeries. So Emmanuel, I'll hand over to you.
Thank you very much. Hello, everyone, and thank you for all the speakers just before me, because it will make easier my presentation, because you are highlighting important things that we work closely at Doctor of the World. But let me introduce myself. My name is Emmanuel Serrano. I'm a policy and advocacy officer for Doctor of the World. I'm from Venezuela, so forgive me if my English is not the best one. My main language is Spanish, so please interrupt me or highlight your questions in the chat box if I don't make myself explain as I should. But I will share my screen now with my presentation. I think it will be easy because we usually start these presentations highlighting the barriers in the access to healthcare. And some of my friends just before mentioned the most of them. But I will go very quickly. No, let me start for what is usually the last bit for me at this point. Doctor of the World put in place in 2018 a GP registration report, a refused GP registration report, with evidence that we gathered in our Doctor of the World clinic in the East of London, plus our helpline that works from Monday to Friday from 10 to 12. I will give you the links for it, by the way. We provide advocacy services for people that come to our clinic looking for access to healthcare, either primary or secondary care. But in terms of primary care, we're trying to register 2,189 patients during 2018. On those 2,189, I think our volunteers, and let me be clear here, our volunteers are wonderful, very well prepared. They know the entitlements of the patients, and they know that each of those 2,189 are entitled to register with a GP, but they fail to register the 18% of them. So almost 1 in 5, we get refused from different GP practice. Many reasons that create these obstacles. But some of them are, for example, the lack of knowledge regarding the entitlements, either for the patient, but also for the GP practice staff. Again, I don't want to enter too deep in this because some of the speakers that talked before me already highlighted. The lack of proof of ID or proof of address, that should not be a requirement. You can ask for them, but it can be a requirement. The stigma about the immigration status, the work from both sides as well, not just for those GP practice that ask about immigration status when they shouldn't. It's also, we need to be aware of this. Some patients could be ashamed to be an undocumented migrant, to be even a refugee or asylum seeker. So we need to manage this with all the care that we can. The barriers around accessibility, like language barrier, that is the most common one. When you do trainings for GP practice, the language barrier is the one that staff members say, well, yes, the language, yeah, because it's the one that works from both sides, for the patients and for the staff. We need to tackle this with Mystic, with doing the extra mile, trying to get an interpreter, using Google Translator if you must, but tackle barrier is super important. And sounds weird, sounds odd, but the fears of being reported to the Home Office is a real thing. Myself, I'm a refugee, and the first year that I was here in the UK, I was an asylum seeker for, I think 13 or 14 months. During that time, I was supporting asylum seekers groups where I met people that was in the UK for over 3 years, and they were super scared to go to a GP practice because they thought they would have the police next day knocking her door to send them back to the country. So this is a real thing. It happens, and we need to be very aware of. But the good news is because we are aware of all these challenges, all these barriers, and all the refused people that we have every year from GP practice, like our report highlighted, is why in Doctor of the World we launched the Safe Surgeries initiative. That is a project to support GP practice. We are here to help, to support, to work with GP practice around the UK. It's a growing community. We have more than 500 GP practice that join this network nationwide. And we are getting close to 600, but I want to give you the details because we are almost there. I just want to say that for GP practice, this is wonderful in your evaluation of the CQCs. And it's being supported by the Royal College of GPs and the Royal College of Nursing. So it's a wonderful initiative to report. It's free, and every GP practice that joins, we provide you a few tools. But the most important tool, the one I want to highlight, so just so you know, I want to give you a head up, is the Safe Surgery Toolkit. That is based on 7 principles that we have. That is basically said, and we explain it better in the toolkit, and we give you the reasons, and we give you the information behind each one of them. But it don't insist on proof of address, don't insist on proof of ID, never ask about immigration status. Super important, keep the information safe. This is something I always tell GPs, because as you know, GPs and nurses are the most trustworthy people in society. So people will tell you their problems. So it's important that you transmit safety. Use an interpreter if you must. Display the Safe Surgery poster and frontline staff with the Safe Surgery training that we provide. But it's not just about the toolkit, what Safe Surgery is all about. We also provide translated patients poster. If you think that in your GP practice you might have some patients that speak other languages apart from English, we could have a poster for you so your patient feels safe in your GP practice. The newsletter, super important. We keep sending information constantly. For example, the guidance and the translated information about healthcare that we put in place every month. So we did a wonderful job. I'm sorry that I'm sharing for ourselves, but the last year during the first wave of the pandemic, we translate in many languages, many information. There is so much information that was super important at the time. But I don't want to stop here. London is doing great, but it can do even better with your help. Because in London, we have a great number of GP practices that joined the Safe Surgery Network, but we want to keep growing. We have amazing work in Lambert, Southwark, Lewisham, Newham, Harrogate, but we want to do even better in Waltham Forest, in Redbridge, in Havering, in Ealing. So we want to increase our number of safe surgeries in London because we want to make London a safe city. Just to, before I finish, I just want to highlight one thing that gives a special importance to safe surgery and GP registration at this moment of time. That is the access to the COVID-19 vaccine. As you all know, right now, tackling the barriers in the access to primary health care will allow people to register with their GPs, and it will allow them to get the vaccine. So if we want to support the vaccination program, we need to tackle these barriers so everyone can register with their GPs and get the vaccines that they need. I don't want to extend any further. I just want to say that please, I will share in the chat box a link tree with all the useful links for GP practice know about satiety. And the first one that you will find there is the Google form to join the satiety network. Please let us know if you have any doubt, any concern about the satiety network. The last thing that I want to say is for each GP practice that you join, we can offer you an online training free as well to support all your practice staff. We always aim to do trainings for receptionists, for GPs, for practice managers, to encourage them to follow the NHS guidance, and as well, as I mentioned, to work with you, to partnership together in order to tackle these things. So we are here, the number of states, we are 580 something, I want to say. It's increasing almost every day. So we are doing very, very well. Last thing, sorry. The good news that I can share now is that we are about to launch an e-learning model for admin staff to train themselves with this e-learning model. So it will be a resource for each safe surgery available, so everyone knows the entitlements for migrants, homeless, and people that are passing through difficult circumstances. So, GP practice are aware, and we can tackle together the health inequality. I don't know if I took more than 10 minutes. My apologies. Sometimes I get very passionate with this. There is any question about it?
No problem. Thank you, Emmanuel. I see the chat box has been very busy with questions, comments, links, and I think what we'll do, we might go straight to our final speaker, Elaine Moorsman, who is going to share the experiences of corner surgery, which has become a safe surgery. And hopefully, just to let attendees know, we are recording this session. If you do need to leave after 2 p.m, we will make sure you get a link to the full recording. Everyone else who's still with us, thank you. And I will hand over to Elaine.
Hi, I'm Elaine. I'm a GP trainee, and I'm presenting about my quality improvement project that I did with Doctors of the World as part of the Safe Surgeries Initiative, which has been a really great opportunity. A bit of background about me. I have been interested in supporting the health of vulnerable individuals for a long time. When I was a medical student, I chaired a charity supporting high-risk individuals, and so I've had my eye on Doctors of the World and particularly the Safe Surgeries campaign for some time. And when I started at the corner surgery, I was really enthusiastic about embarking on this project, because I'd noticed that Doctors of the World were supporting trainees to do quality improvement projects. So the corner surgery is a practice in Denmark Hill. It's quite near to, in fact, it's right next to King's College Hospital. And I have to say, when I started there, the corner surgery was already a safe surgery, and they didn't ask for ID at the point of registration, and they offered patients a translator for all appointments, telephone and face-to-face appointments if they needed it, and English wasn't their strongest language. So I was very lucky that I already came into a practice that was very open to making these changes. And when I started there, my trainer, David, was, as part of my induction, encouraged me to look around the local practice area just to get to know the area, and also to kind of see the places that people were living, and also to research a lot about the type of the population. So I was able to find out that Lambeth is a relatively deprived area in London, that there's high incidence of mental health problems, high incidence of child obesity, and high incidence of drug and alcohol use. I was able to meet with Yusuf, who works at Doctors of the World, over Zoom, to discuss the possibility of doing a quality improvement project at the corner surgery. And I was really supported by David, my trainer, and was also able to engage other staff members, including the practice manager, Eva, and the reception manager, Kyron. So when I met with Yusuf, we were able to talk through the steps that we would need to go through in order to make the corner surgery a truly safe surgery. So even though we were already implementing a lot of the policies and the partners were aware of the NHS England and wanted to make sure that were aware of the policy as welcome as possible. We wanted to make sure it was written into the policy. So if people were all to change, if all the staff members were to change, then you would still have a safe surgery because people would fall back to the policies and it would all be written in there. We wanted to offer some training to the staff and then once we had implemented the training, to reassess people's knowledge and values and then go on to share those findings, which I'm actually doing this afternoon at the corner surgery. I'm giving a presentation at the practice meeting as well. So in terms of the policy and practice review, I sat down with Eva and Kyron and we looked at the practice registration policy to make sure that it was clear that people should not be asked for identification and proof of address, and also see if there are any other areas in where we could support people. And one of the things that we did is we created a registration flowchart, which basically takes any staff member through the steps of registration and makes it very clear that certain areas are focused on. And it was really useful for the practice as well, because we were able to overhaul the whole registration policy and make sure that there were other things, not just the Safe Surgeries initiative, but other areas that were important to the partners, to make sure that we'd overhauled the whole thing, so it was kind of mutually beneficial. I was getting what I wanted out of it, and so were they. And we were also able to look at the new patient questionnaire to make sure that we were asking patients questions to make sure that we could support them as much as possible, in particular if they needed help with healthcare costs. And positive consents for a shelter. So if they couldn't ask another staff member, they were working on their own, they can refer to this. And again, all of the safe surgery policies would be clearly written in there for them to follow. And finally, we put up posters to make it clear to patients that were coming in to register were aware of the policy. You can start when you feel lost. Thank you. Thank you. Sorry about that. So this is the registration flowchart that we created. So you can see that a patient would arrive to register. We check that they fell in the catchment area, give them a questionnaire to complete, and then when the reception staff review the form, that's one of the most important steps. They would be able to make sure that all of the details were included, and then as they came across things that they wanted to, that the patient had highlighted as an issue, they could then make sure that the relevant members in the practice were aware of that. But in particular, where we ask people to check their ID, we've made it really clear that the corner surgery is a safe surgery, and that we don't insist on ID at registration, and that we don't insist on them having an address. And then I can also a picture of the posters that we put up, making it clear that people don't need documents, and also that their immigration status doesn't affect their right to register, to make it clear that they are safe when they come to the corner surgery. So in terms of staff knowledge and attitudes, we sent out a survey that had quite a good uptake, just assessing all of staff knowledge on the NHS England policies, just to make sure that to see whether people were aware, and also some of their views and attitudes towards people that may have come from overseas and with uncertain immigration status. And then Yusuf from Doctors of the World very kindly delivered a training session on one of our practice learning days. So it was a practice-wide training to ensure maximum uptake. And then at that point, I actually went on maternity leave. But after 3 months, we were able to resurvey the staff to see if any of the changes to people's attitudes and whether the changes to the policy had caused long-lasting changes. So just a brief overview of things. So you can see here that the blue bar is before the training and the orange bar is after the training, and then the grey bar is to show the increase in people's understanding. So the grey is the increase in people that got the questions correct, and we didn't see a decrease anywhere in the knowledge area, so that was really good. So people became more aware that people don't require documents when registering with the GP, that people don't need photo ID and they don't need proof of address. And then they became more aware that they didn't have any obligations to break confidentiality to the Home Office, and unless there were very specific issues such as serious criminal activity or a safeguarding concern, that they didn't need to share any information about patients outside of the practice. And then in terms of attitudes, on this slide, the further towards the left, people's attitudes were more positive towards vulnerable people. So more people felt that people should be able to access GP services that needed it. And again, here, people felt that people deserved a translator so that they could consult in their own language. And then on these slides, it's the further over to the right, people were supportive of vulnerable people. So this one just shows that people didn't feel that it was their responsibility to report people that potentially had uncertain immigration status to the authorities. So again, a positive change in people's attitudes. And here again, people felt more that it was not their responsibility to deal with health tourism after the training. So just to give you kind of an idea of what it's like as a patient to walk into the corner surgery, since we implemented all these changes, they come to the door and they see that it's a safe surgery and that they don't need to have documents. They come to the reception desk and they have friendly reception staff who are ready to offer them a translator if they need it, or even book them in for a telephone appointment to go through the registration documents so that they can fill it in over the phone with a translator. And the reception staff are also have been educated to try and identify people that might need the help of a social prescriber or a health coach. And then they can sit in the reception area, and we have some videos, and we're working to get some Doctors of the World videos about vaccination to give people information about how to access vaccinations when they're actually sitting in our practice. And in the future, Emmanuel mentioned the e-learning module. We hope to offer that to our the people in our practice, and the reception. The website at the moment doesn't clearly state that we're a safe surgery, and there's recently been changes to it, and we're hoping to update it to make it clear when people go to the registration page on the website that it's a safe surgery for those that are able to access the internet. So thank you very much. If anyone has any questions, I'm going to try and turn my microphone so I can hear you again.
That's great. Thank you so much, Elaine. Really interesting to see how things are looking at safe surgery and the different ways you've been working to overcome many barriers which have been mentioned. So I think as we are past 2 p.m, we might have to wrap up from here. I'll hand over to Jasmine for final thoughts, but again, we will be sharing various resources which have been shared today. Again, our slides and a link to the recording. Jasmine, if you'd like to talk briefly about next steps following today's session.
Yep, great, lovely, thanks. And thank you so much, Elaine. Really, really powerful and useful to hear that approach in terms of how your surgery has sort of been used as a safe surgery. So just to outline in respect of the following up event. So we've had a great host of speakers today, and it's covered quite a broad sort of aspect in terms of both homeless and inclusion health and the registration process in particular. The next event that we're holding, so it would be the second of this two-part series, is in relation to sort of London specific. And I know we've had colleagues from sort of on a national sort of picture join us today, which is fantastic. But the next event that we'll have will be sort of working again through sort of the hosting through HLP, and then breaking out into ICSs, so local ICSs, and having a bit more of a work through session in some of the detail and some of the presentations. So for example, with regards to safe surgeries, so you can have a closer discussion and have a look at the sort of map in relation to how it is in your local boroughs. We're also sort of looking to try and get some cases to go over and to discuss, and to sort of work out where sort of there may be gaps within your provision in your sort of local patch, and how we could sort of how ICSs could potentially look to sort of address those issues. If there's anybody in particular who is from those London ICSs and interested to join us in that sort of those sessions, please do sign up. As I said, in respect of it is open, but it is really quite London specific. And if anybody from those ICSs are interested in helping us to develop those events for their local patch, then please do get in contact and let us know. I just want to say a huge thank you to all of the speakers today. They've done absolutely fantastic. And if, as we've not been able to sort of address any particular questions around the safe surgeries today, please do email over or continue to write things in the chat, and we can look to address those in the circulating documents that follow. And thank you again, and have a good rest of the evening.